Okay, in this session we'll break down each injury type. Remember we said that there are four main types of injuries that affect the chest cavity or the thoracic cavity, and that would be skeletal, which we'll start talking about here with rib fractures, pulmonary, which affects directly on the lungs, the heart and great vessels, and then diaphragm and other structures in the cavity itself. So we'll start with our chest wall injuries or our skeletal injuries with rib fractures. And rib fractures is a good place to start because it's one of the most common thoracic injuries. The pain from a rib fracture, even if it's just an isolated fracture, can actually cause a lot of damage. People tend to self-splint, so they'll take much more shallow breaths, trying not to breathe deeply because it hurts so much when those ribs expand and those bones grind past each other. This can lead to atelectasis, so the alveoli stop inflating and deflating as easily, and eventually can lead to pneumonia, just from that inadequate inflation of those alveoli that allows invaders to basically fester and infection to develop in those airways that are not being expanded properly. Okay, so we're checking out our ribs. Another thing that we have to consider when we talk about rib fractures is what age group we're talking about, and our patients themselves. So if we're looking at a pediatric patient, we can see that when they have damage to their thoracic cavity, their ribs are much more pliable and they tend to absorb much more force. The cartilage is more prominent than the bone, and that leads to less rib fractures in general. But that energy has to go somewhere, and oftentimes that energy is just transferred to the organs that lie underneath. So you have to have a high index of suspicion and really be careful, because you may not see any broken ribs or anything on the outside, but there's been damage to those organs underneath. In fact, you can have a pediatric patient, say a 4-year-old, be run over by a car, and the only thing on the outside obvious they were run over by a car is maybe some tire tracks over their chest. No broken ribs. They may not even have significant bruising at that time, or significant swelling. You may just, like I said, see the tracks that go over. But where did that energy go? Well, it was transferred to those organs underneath, and that's what we would be most worried about. And this is as opposed to somebody who's, our geriatric patients tend to have bones that are much more brittle. Osteoporosis is set in, and they're much more susceptible to fractures. And then those fractures, as we mentioned before, if they're allowed to self-splint, not take deep breaths in, pneumonia tends to set in, and that causes quite a few issues. So we're looking at our different patients, our different age populations, and we'll see different presentations based on those. Like we mentioned, when we're assessing the chest, we have our hands on the chest, we're palpating, we're looking for DCAT BTLS. We're also looking for that subcutaneous emphysema, that tenderness, instability, and crepitus that we talked about. And blunt fracture can actually cause an issue right at that location, that point of direct impact, and it can also travel. That energy could actually travel around the bone and actually fracture on the other side, or in the case of a clavicle, it can go up through the arms, and then the clavicle itself could pop. So just things that we tend to see. Okay. So, as we mentioned, the we're assessing everything. When we talk about the ribs themselves, we have 12 different pairs of ribs that we'll really focus on. Ribs 1 through 3 are very well protected. In the anterior chest, they lie under the clavicle. On the posterior side, the scapula goes over them. So these are very well protected area. So if they break one of these 3 ribs, that is a really bad sign. That means that that patient sustained a great deal of force, and we're probably looking at a multi-systems trauma in that case. Ribs 4 through 9 are actually what's most often fractured, and we'll see what organs lie beneath those that we have to worry about if one of those fractures should come loose and become displaced and actually puncture an organ below them. They could have even more significant damage. And then, our 10 to 12 ribs are more of our floating ribs. They tend to have a lot more flexibility, and they're more pliable because they have all this cartilage that attaches them, and they're a little bit more distant from the sternum, so they tend to just flex a little bit more. All right, so thinking back to that picture and looking at those areas, what's going to be affected when ribs 4 through 9 are hit? Well, our lungs lie right below there, our heart lies right below there, our trachea runs through that area, the aorta's in that area. Those are obviously definitely things that we have to worry about. 9 through 11, we really start to think about where that diaphragm was when the injury took place, and we're wondering if we have an abdominal injury to go along with our thoracic injury with those ribs, with the liver and the spleen lying up under those, and the kidneys on the back side, kind of having a little bit of protection from those ribs. A lot of times with rib fractures, people have point pain where it's located, and eventually that would become a more diffuse pain. They might be suffering from a little bit of difficulty breathing, and they'll have that tenderness in that area. You might see bruising and swelling. You might actually, when you palpate, feel those bones kind of move back and forth, and might even get a little bit of that subcutaneous emphysema in there. Like I mentioned, patients tend to breathe much more shallowly because when they take a deep breath, it hurts more, so they don't take a deep breath. So one of the things that we want to do is provide some pain management so that they stop self-splinting, because even though they might not be trying necessarily to do it, but the body itself starts to self-splint and starts to take much more shallow breaths. So we really need to do a lot to encourage them to continue to take deep breaths, to cough, and provide them a little bit of pain management. So we're going to focus on our ABCs, as always, give them a little supplemental O2 to help them out, and then, we can consider splinting that chest wall. We just need to make sure that we're not doing anything that restricts their chest wall movement. So we wouldn't want to wrap their entire chest circumferentially, because that could limit the amount that they're able to expand and contract. A great thing to do when you have a patient who is alert and oriented is give them a pillow or give them a blanket that you've rolled up that they can actually hold against their chest wall, and that will help to diffuse some of that pain, help to stabilize, and allow them to take deeper breaths. And then we can also consider some analgesics for pain. Now, when you have 2 or more ribs broken 2 or more places, you can actually get a free-floating segment known as a flail segment. And you'll see here these ribs, 2 or more, broken in 2 or more places. So this is now free-floating. And what tends to happen is this moves in opposite direction as the rest of the chest cavity. We see this a lot with blunt forces, and not even necessarily just a blunt force to this area. It might be a blunt force to either the front or back. and these might just happen to be, weak points where they pop out. Or it might be that the person got hit with a baseball bat right here, and that broke those ribs in those places. So basically what happens is if you're thinking about this regular lung here, this section, remember when we're taking a breath in, our intercostal muscles have retract and caused our chest to move up and out. Our diaphragm has contracted and moved down, and that creates more space in that thoracic cavity. That increase of space with the same amount of gas in it causes a drop in the pressure, and that's what causes the air to rush in from the outside to try to balance off that pressure. So that negative pressure acts on that flail segment, and while everything else is moving, let me get it here, everything else is moving up and out, that flail segment moves in, so it's moving opposite of the rest of the chest, and that decreases that air volume that lung is able to intake. On expiration, it does the opposite. So on expiration, everything is relaxing, and that chest cavity is shrinking down to its normal size. That creates increased pressure in that chest cavity, which is normally what blows the air out. But that flail segment is affected by that increased pressure, and it bulges out. This is very painful, and again, why patients self-splint. And also, again, that means that this lung isn't being deflated, so that on the next inspiration, it's not getting fresh air, it just has old, stale air in there. Right? Flail segments aren't always, immediately apparent. Sometimes all the muscles contract and stabilize, but we need to constantly reassess. And then, we may need to provide positive pressure ventilation in order to properly ventilate that patient and allow for good oxygen exchange. As part of that, again, with treatment, you may hear things from the past about how we'd put sandbags or IV bags on that flail segment to hold it in place, and that's really not the case. If your patient is unresponsive or has an altered mental status where they can't really follow commands for us, we'll just leave that flail segment, note it, and then treat with positive pressure ventilation if needed. If the person's alert and oriented and can follow commands, and they can hold a wrapped up blanket or a pillow against that fracture point, and that's really going to help reduce the pain. And reducing the pain will lead to a better ventilatory effort because it provides that stabilization, which helps to relieve some of that pain. It also provides a little bit of stabilization so that part doesn't pop out, on that expiration process, and so it helps with just overall ventilations as well. But just to reiterate, we no longer put sandbags or IV bags or bulky dressings taped down to the other side over a flail segment. What they found was that was actually restricting the movement of the chest, and causing more problems because it was restricting that chest movement and not allowing the lungs to fill completely with air. Is causing atelectasis and further leading to pneumonia. You can also have a bruising that occurs because that force was great enough to break a few ribs, so some of that force may have been transferred to the lungs, to the cardiac system and beyond. You can also have pneumos and hemos that develop because of those fractures in that free-floating segment. Remember, those bone ends are very sharp, so you can have shards of bone that puncture lungs and other organs in the cavity. Alright, so what would we expect on our assessment? Well, probably some tenderness, instability, and crepitus. We might have some subcutaneous emphysema just because there's been a breach in that wall, and difficulty breathing. On the affected side, you might hear diminished lung sounds, or there, because that movement isn't as controlled as it is when there's not an injury, and you might have diminished lung sounds just because they're breathing so shallowly. So if you can address that with some pain management or some positive pressure ventilation for those folks that are unresponsive, you're going to get a much better ventilatory effort. Just like we're saying here. So because of that shallow breathing, because of that decreased ability to exhale, they might be suffering from hypoxia. They can start building up their CO2. Again, that section is moving. It's not allowing that rib to completely deflate. And these are very painful. So we pretty much covered this. We want to keep our SpO2 high. And like I said, we might need to supplement with either just some oxygen, or if they're not responsive or they're struggling, we're going to have to assist their ventilations with positive pressure ventilation. All right. Sternal fractures. Sternal fractures are very, very difficult to create. So if your patient has a sternal fracture, as we see here in this x-ray, then that means that their body sustained a great deal of force. So we have to be very suspicious that the underlying organs have also, been exposed to that force and are probably damaged. So these are, we're probably thinking that we could have not only pulmonary contusions, but cardiac contusions, potentially cardiac tamponade. We could have pneumos, hemos. Just a very high level of force is required to fracture the sternum. So that increased force leads to a very significant mechanism of injury, and I better have a really high index of suspicion when it comes to injuries of those internal organs. So I'm going to be, constantly reassessing this patient because they can, deteriorate rather quickly because of the vessels and organs that lie below. They're going to have pain usually over the whole front of their chest, and while they, might be able to point to some point pain, point tenderness, it tends to, be a little bit more diffuse over that entire sternum. If the entire sternum has been broken away, you might even have the sternum itself might be the flail segment, or you might have a flail segment that also accompanies it. What are we going to do? Well, we have to have a very high index of suspicion on, those organs below it being damaged. So we're going to need to monitor the lungs very well. We're going to need to monitor the heart, which includes putting them on an ECG, and, manage any associated injuries, because there's a good chance that this is a multi-systems trauma just because it takes such a high level of force, which suggests a pretty significant mechanism of injury to have this happen. Clavicle fractures, on the other hand, take little force to get a clavicle fracture, and this is one that I kind of alluded to before, where the can actually be caused by hitting. It can be a secondary kind of fracture, where let's say somebody falls, they put out their arms to brace themselves or catch themselves, and that force travels up the arms and hits a weak spot in the clavicle, and that's where it pops it. A lot of times these folks will, as they kind of self-splint themselves, they'll actually hold onto their arm and across the front of their body because it hurts for that arm to dangle, and they don't move that arm, they just hold it in place because any movement becomes very painful because that clavicle, intersects at that shoulder, and any movement on that arm moves it. You can see here in the x-ray the fracture here on through. Now if that bone is not displaced, which this probably needs to be moved back into place either by manipulation from the outside, or going in and putting in a plate, and moving those together. But if it's not displaced, a lot of times they just let it heal in place. They might just put the person in a sling so they're not moving that arm around much, and let it heal that way. If it was a direct impact to that clavicle, then again I'm going to be very suspicious for where the rest of that force went. Did it travel to the ribs and to the organs that lie underneath? Alright, so if it's an isolated, clavicle injury, we're just going to sling and swap it. And, we want to, make sure that we make the person comfortable. Sometimes it helps to put a little bit of padding under the knot that goes on the neck, to, just keep that material from digging into their skin and the neck region. Alright, now we'll, move on to our pulmonary injuries. So, rib fractures, flail segments, sternum fractures, clavicle fractures. Those are more relating to the chest wall and the musculoskeletal side of the house. And now we'll talk about the pulmonary injuries that we address in this region. A simple pneumothorax is just that. There's no opening to the outside. It can actually often just heal up on its own, and they'll just watch the person, and unless it's a significant hole, and then we'll watch for it to go to a pneumothorax as well. But basically what it is with a simple pneumo is you have a breach in the lung, so in the covering that goes around the lung, that visceral pleura has been breached. It allows air to escape in that pleural space between the parietal pleura on the outside of that cavity and the lung itself, and the air ends up filling this space. And the lungs are very spongy, and they are very pliable. So if I have air building up in this space, it creates a pressure in this cavity, and it keeps the lungs from expanding. So it can actually keep the lungs in a collapsed state. And the more air that gets in there, the more that lung will actually start to collapse. So this is one of those, I feel like reading x-rays is a magical thing, and I really am not good at it, but what you can see here in this x-ray is you can see how you have more clear here, representing more air in this space. So there's likely a pneumo probably somewhere in here, and it's leaking out, and you're getting air that's just filling this space. So you can actually see where my mouse is. This is the lining of the actual lung. And this, where these arrows are actually the lining of the cavity, and everything in between is where air is filling up. Where on this side, you really can't see that gap between the cavity and the lung itself. Alright, how do, simple pneumos that, are able to resolve, how do they present? The person might have a little bit of difficulty breathing. They'll probably have chest pain, and they can probably point to about where it hurts, so it hurts up here, hurts down there. And the breath sounds over that damaged area are going to be diminished. You might have hyperresonance, which, if you tap, it's much more hollow sounding because that space is now filled with air as opposed to tissue and fluids. If that simple pneumo or small pneumo progresses, it can actually cause even more problems, cause increased difficulty breathing, and, start to show, or start to put serious pressure on the rest of the organs in that cavity, including, the other lung and the heart, and that's when it switches to, more of a tension pneumo. Basically, what are we going to do for those folks who are having some mild difficulty breathing? who we suspect have a simple pneumo. So simple being it is contained. There's no breach in the outer skin going into that cavity, and the hole is just between the lung covering and the cavity covering. All right, so that would be our simple pneumo. It's not an open pneumo or a complex. It just stays. It's just all very contained. And this can happen for a number of reasons. Blunt force tends to do this. You'll have somebody will pop a lung because they get tackled, or they're taking a deep breath in because they realize they're going to crash, and then they hit the steering wheel, and you get that kind of paper bag effect where it can pop a lung. And this can also happen spontaneously. And folks who are thin, young, tall males, for whatever reason, tend to have more spontaneous simple pneumos. So if I had somebody who complained of difficulty breathing that had a sudden onset, my two choices that I always go back and forth with somebody who has sudden difficulty breathing, came out of nowhere, now I'm having difficulty breathing, I always suspect either a pneumothorax or a PE. And if it's a tall, thin, young male, I'm leaning more towards spontaneous pneumo. And if it's a female, I would, especially somebody who's over 40, I would lean more towards PE. So that was a simple. Remember, simple is there's no outer, there's no breach in the outside skin. An open pneumothorax, on the other hand, there is a breach to the outside skin. So either a rib has poked all the way through, or you have some sort of penetrating trauma that has, caused a hole. And now air tends to rush in from the outside and fill that space. And also, when that pressure increases in that area, it tends to leak out of that hole. And that movement of air through the skin, through all of the tissue, between your lung and the outside of the skin, and all those fluids, it tends to bubble because of that air movement. So you'll hear, this, and also as the air comes in to that negative pressure, you'll hear an actual sucking noise. So this is this like sucking, bubbling wound that you see. As soon as you see that, then again, that is a life threat. We need to put a gloved hand on that and follow it up with an occlusive dressing. An occlusive dressing meaning one that is not penetrable by air. I'm going to cover that up. Air is going to take a path of least resistance, so it's much easier for it to move in and out of this direct hole here than it is to come through the typical airway of the trachea, the bronchiole, or the bronchi, and going down to the bronchioles. So it'll make it, make its way out. And like I said, a lot of times you get those bubbles and that frothy looking blood around the wound, and you might actually hear a sucking noise, which is where it gets its name, the sucking chest wound. Which is right here. Alright. Again, if the vasculature is intact and the lung is just being compressed, then the heart's going to continue to perfuse that collapsed lung, but you're not going to get a good gas exchange because the lung itself can't expand, those alveoli can't expand to allow fresh oxygen to come in and do that gas exchange. You may also, obviously it's the hole here, there might be crepitus, the ribs around it might be fractured as well, and because there's that breach and air is rushing in, you might get air in the tissues here and you might have that subcutaneous emphysema. An obvious sign would it be if there's an impaled object still sticking out from it. But remember here, when we look at this picture, I want to know what he was stabbed with, or what, did this puncture. And I'm going to consider the length of that object, and then consider that cone of damage that can occur. So imagine sticking that, if it's a knife, sticking that knife in to that hole and twisting your wrist around. What could it hit? And in this area, obviously we were thinking it could hit the lungs, but what else is laying here? If you said spleen, that would be on this side. If you said liver, that is correct. So we have, damage for a lot of, or potential for a lot of blood loss in here as well. You can also have, if you hit a hollow organ, you could also have contents spill out, and that could cause, sepsis and things along those lines. All right. What are some of the things that we're going to see with that? Well, that sucking wound itself. But then the body's going to respond, right? So it's not getting enough oxygen, so what does it do to compensate? It's going to breathe faster. The heart rate is going to go faster, and you're going to start to see some changes in the level of consciousness. And remember that anxiety, anxiousness, that restlessness are initial signs of hypoxia. And as that pneumo increases or gets worse, then you're going to hear less and less breath sounds on that side. So they're going to become much more diminished, which is why you have to do that direct compare, apex to apex, base to base, see what it sounds like. So what are we going to do to manage it? Well, just like I said, we're going to throw our gloved hand over it just to cover it while our partners get an occlusive dressing, and we're going to tape that dressing down. So we talk about taping it down on 3 sides. What we're really doing is we're taping it down enough to not allow that to, suck any air in. So we want this down, and if that means you have to tape down all 4 sides, that means you have to do it. What's nice is if you're able to leave just a little bit untaped, one, it's a good spot to take to pull off so that you can burp that wound, but also sometimes it can self-burp, and if the pressure increases in that chest cavity, it'll actually release some air through this path of least resistance through that one side. But you're going to know on your patients. If they're alert and oriented, they're going to be able to tell you, hey, I can't breathe. And that means you're going to need to burp that dressing, which means, just pull it up a little bit to let some of the air out. If they're unresponsive, and let's say you got this, dressing in place and you're bagging them, and you're having difficulty bagging them, you're having a hard time keeping a seal, or that BVM is making, that awful noise it makes when it's hard to squeeze, then there's a good chance that you've built up too much pressure in that chest cavity, and you need to burp that dressing. All right. Because there's an outside hole, you often these don't convert to tensions unless this becomes completely sealed. Unless you don't burp it when you recognize that they're not doing well, or if the body itself starts to seal itself and clots this off, quickly. But often with open pneumos, we don't worry about them going tension as much, just because there's a hole for that increased pressure to escape from. All right, so this just shows this is a commercial chest seal, and you see that it has this tab here so that you can pull it up and burp it when needed. But just because it says, it's rare for it to go into a tension, that doesn't mean that it doesn't happen. So we are going to be, just like with our simple pneumos, we're going to be constantly reassessing these patients and ensuring that they haven't gone down the route of tension pneumo, because tension pneumo is a life threat that we need to address, and they can die very quickly from that. So speaking of tension pneumos, again, now we have this hole. This chest cavity is filling with air. There's nowhere for that air to escape, either because there was never an opening to the skin, or that opening has sealed itself off, or you've sealed it off. And so that air just keeps building up pressure and pressure and pressure inside this chest cavity. And that increased pressure pushes on that lung and collapses that spongy lung, and then it starts to push on that other side. So it goes through the mediastinum, which includes the heart and the great vessels, and it starts to put pressure on the other lung. In that process, we talk about how the venous side, or that vena cava, is on the low pressure side of the house. So as that pressure increases with the chest cavity, it can actually collapse that vena cava, which will drop our blood pressure. It drops the preload to our heart, and eventually drops, which causes an issue with the cardiac output. And then it can actually compress the heart as well, which does not allow it to expand and fill up with blood as easily. So this starts to cause lots of problems. I'm not being able to use this lung. I have my great vessels collapsing, my heart unable to expand as easily, and then the other lung starts to collapse as well. So this is a definite life threat. And if we listen to lung sounds here, we would hear louder lung sounds on this side and diminished lung sounds or absent lung sounds on this side. But just a reminder, you might still hear lung sounds here, so I need to do a direct compare and listen apex, apex, bass, bass, mid-axillary, mid-axillary, so that I can hear the difference in sound between the two lungs. On this x-ray, you can see this line here is our lung tissue. Alright, so that lung is being compressed, and this entire area here is filling up with air. Okay, and it's causing this lung to squish down. You can see that it's also pushing, that pressure is pushing over to the good side, so you're seeing everything kind of take a shift to that left hand side of the body. And if we could see the trachea here, we might see that it would start to shift. Now that can be a very late finding because think about all the structures in your neck and how everything is holding it in place. So it takes a lot to really pull that trachea over to the other side. But obviously, if you see that tracheal deviation, we're going to be very suspicious of pneumo. Right. So as that builds up, obviously that lung can't expand, so we're not able to bring in fresh air with fresh oxygen. We're not able to do that gas exchange and bring oxygen in. We're also not able to get rid of CO2, so their capnography readings may start to increase. And this is what we talked about, where that pressure increases and causes that mediastinum shift, so everything's shifting to the other side. Alright, so what are we going to do? Well, when we find that, when we suspect that we have a tension pneumo, and some of the big giveaways are absence or diminished lung sounds on the affected side, unequal chest rise, so the hands, or the one side of the chest will actually become hyperinflated and it won't go down. You may also notice pulsus paradoxus with your patient, where the blood pressure actually changes by 10 millimeters of mercury when they take a breath in, and that's due to that pressure being put on the great vessels in the heart. Typically they have tachycardia as they're trying to compensate for their lack of oxygen. It can cause them to go into dysrhythmias as the heart becomes hypoxic. And you may see JVD, especially if there's no other bleeding involved. If there's other bleeding somewhere, then you may not notice the JVD because of the blood loss and the low BP. Pulse pressures tend to narrow, so the systolic starts to drop down to the diastolic pressure. And like I mentioned before, tracheal deviation is a very late sign. Alright, so this just kind of highlights what those issues are. So they tend to become a little cyanotic, very anxious. If they're alert and oriented, they become very anxious, very restless, and agitated because of that hypoxia. You might see some JVD, and again, that's properly assessed when they're sitting at a 45-degree angle. But if they're laying down, you will see those jugular veins, like bulging from their neck, more than a typical person. Possibly some subcutaneous emphysema under the skin, and diminished or absent breath sounds in this area, right? And they're going to seem shocky, so they're going to seem cool, pale, or cyanotic and diaphoretic. Alright, so what are we going to do for them? Well, we need to relieve that pressure, and that's really the biggest thing, because that pressure is causing all of that damage, and basically it just boils down to us relieving that pressure. Alright, so it's just kind of going over those signs and symptoms that we just discussed. Alright, so what we're going to do to fix that pressure is actually do a needle decompression. And to do a needle decompression, we're going to use a needle, a 14-gauge needle that is at least 2 inches, but preferably 3 to 4 inches in length. And we're going to find our landmarks. We're going to go mid-clavicular between in that third intercostal space, so that's right in between the second and third rib. And remember to find that. You can follow your clavicle over to the sternum, and that first rib lies just under the clavicle, so under that you'll feel, as you follow along on the sternum, you'll feel that first little dip. That's your first intercostal space. And then the next dip is that next, you'll feel the next rib, and then you'll feel that next intercostal space. And that's where we're looking to go. So then you follow that around to the mid-clavicular area, and we're going to take our needle, clean our site, and then pop it in perpendicular to the skin until you feel that pop. And that's how you know that you're in that space. You may hear a whoosh of air that comes out as that pressure is relieved. A lot of times our scenes are a little chaotic and noisy, so you may not hear that rush of air, but what you will see is a change in your patient's condition. You'll see equal chest rise and fall, you'll hear lung sounds again on that side, and their pulse ox will come up, their capnography will start to fall, and they'll become more pink than pale and blue. Remember, we want to go right over the ribs, so you're almost hitting that third rib and then popping it over, because we want to avoid the vasculature and the nerves that run right below each rib. Alright, so in addition to air filling up that space, you could have blood filling up that space, and when it's blood, it's called a hemothorax. And that's usually a nick in a vessel in this region, causes blood to fill this space, and again, fills with pressure. Those lungs are very pliable, they can't handle the pressure, and so it starts to collapse. Very similar presentation with the difficulty breathing, diminished lung sounds on that one side. Now, instead of it being hyperresonant, if you were to percuss, it would be very dull sounding because it's filled with fluid. And if that fluid continues to build up, you could actually see that tracheal deviation. You tend to not see JVD in this case because that blood tends to be dumping in to that chest cavity. Or you may not see JVD in that case. So in this x-ray, you see the white is where all the fluid is, so you see that there's very little space for air. And not uncommon for it to fill the lower bases first, because the gravity pulls that fluid down before it starts to go all the way up. Pretty much what we talked about. So we're going to be treating them for shock and this person is going to get a chest tube placed. We can try a needle decompression if it turns to tension, but oftentimes that blood clots in that 14 gauge cath and doesn't do as much good. Alright, so again, just kind of going over, you'd have more of a dull percussion over that side. Neck veins tend to be more flat because the blood is draining from there directly into the pulmonary cavity here. And again, they're going to be pale, diaphoretic, possibly cyanotic, and having difficulty breathing. Alright, so we want to give them circulatory and ventilatory support and take them to a trauma center. Pulmonary contusions are, very common in as a secondary issue to all of these primary issues that we've talked about, and it's suspected that 30 to 75% of blunt trauma has a pulmonary contusion to go along with it. This is significant because the mortality rate when you have a pulmonary contusion is about 14 to 20%. So 14 to 20% of the patients that have pulmonary contusions die. And what is a pulmonary contusion? Well, a contusion is a bruise, so it's basically a bruise on the lung. So you're going to have the small capillaries that are damaged, and they leak fluid and blood into their surrounding tissue. You're going to get your immune response and your inflammatory response to that area, so it's going to bring along with it some edema, and all that space that's being affected, all that was damaged, is no longer being ventilated properly. As that fluid fills up in that area, it tends to dilute the surfactant that surrounds those alveoli, and that causes atelectasis. Those alveoli can no longer expand with the fresh air that's coming in. Because those alveoli aren't functioning properly, their O2 intake is decreased. This causes hypoxia from the body, and then the body itself tries to fix the problem. Well, I'm leaking blood there, so what am I going to do? I'm going to shunt blood away from that area, and that tends to make the problem even worse. Alright, so how are they going to present? Again, difficulty breathing. They might be breathing fast, their heart rate might be up, they might have that agitation or restlessness, which is those beginning signs of the brain becoming hypoxic, and there's a mechanism of injury that goes along with it. So, they got hit with a baseball bat, but you don't see any broken ribs or feel any broken ribs, but they're having these issues, and I have relatively good lung sounds, or I hear wheezing or crackling as that area starts to fill, as that edema sets in, as opposed to just completely diminished, then I would suspect more of a pulmonary contusion. Alright, that's basically what I just said there. So what are we going to do? Well, we can help them out a little bit for pain, but our biggest treatment is going to be recognition and transporting them to the hospital. We're going to assist with their airway breathing and give them circulatory support, although we're not going to overload them with fluids, right? So we just got to keep in mind that our ultimate goals for fluid resuscitation is to keep them in the perfusing region, which is right around 90 systolic. We don't want to give them too much and cause more swelling in those areas. And our other general rule is 20 milliliters per kilogram for our boluses. So that summarizes everything that happens with the lungs that can cause these issues. So we've talked about a simple pneumothorax, an open pneumothorax, tension pneumos, hemothoraxes. You can actually get a combination of those two, so you can have a hemo-pneumo, and that's going to present very similarly to a pneumo, except you may not have that JVD again because of the hemo portion of that. So now let's talk about the damage to the heart and the great vessels that can significantly impact our patients and contributes to that 25% death rate with chest injuries. So one of the biggest ones that we'll talk about is cardiac tamponade, And cardiac tamponade occurs when that lining that surrounds the heart, that pericardial lining, becomes filled with fluids. So in trauma patients, we tend to see this as blood fills this fluid. You can also see it if there's an infection raging and you're getting edema from that infection. But since we're in the chest trauma chapter, we're going to talk more about the blood filling that space. So the blood starts to fill that space. The heart itself is not able to expand to fill up with blood to be, so that preload, it's not able to pull in as much of that preload, so then your cardiac output is reduced, and that causes problems for the entire body. As it continues to fill, the heart becomes more and more compressed and functions less and less. So the rate at which this happens, or how unstable they become, is really dependent on how big of a leak there is, right? So how's it leaking? What's able to get in, get out? Is the pericardium itself completely intact? Is there a hole there that the blood is then seeping out of that? And what part of the heart was injured? Because if it's one of the left ventricle, you're going to have a lot more blood pumping through that or spurting out of that hole than you would, say, the right atrium, just because it's a much more high pressure side of the house. It's a bigger portion, and it's much stronger, so the contractions through that are much stronger, which means that every time it contracts, it spurts blood out of that hole a little faster. Alright, so as I already mentioned, it can happen with your medical patients as well as our trauma patients. With the medical side, tends to be an infection present, so you have a slower buildup of signs and symptoms, whereas with a trauma, it's usually an injury, it's bleeding, and it fills up with blood that much faster. Alright, as it fills with blood, it not only puts pressure on the heart, but it starts to put pressure on those great vessels that surround it as well, which also decreases the preload. And the heart is going to try to beat faster to compensate, right? Because cardiac output is equal to stroke volume times heart rate. And if my stroke volume is going down because my preload's going down and my my heart itself can't expand, it's being compressed, then it's going to try to compensate by increasing the rate. And this can actually work against it, because if that hole was in that left ventricle or on that side, as that rate increases, it just spews out blood that much faster. Alright, so we talk about Beck's triad with cardiac tamponade, but only 10 to 40% of those with it will have Beck's triad. So that includes muffled heart tones, hypotension because cardiac output is greatly reduced, and JVD because there's that obstruction going to the heart and that blood backs up and pulls to the periphery. So it backs up into the vena cava, which backs up into the jugular veins. A finding that is much more common is electrical alternans, and that's where you'll actually see a difference in the size of your QRS complex between your different beats. So you might have one QRS complex that's very small, and then you might have one that's much larger. And you see this, I kind of imagine it as, the heart's being compressed, then that signal is also being muffled by the fluid, but every once in a while that heart's able to give a big enough signal to break through the fluid, and so you see a bigger QRS complex, or a taller QRS complex, because of it. They're going to present just like they're shocky, right? So, the only thing that being a little different than our shocky patients would be that JVD. Heart tones, you're not going to know they're muffled unless you listen to a lot of other heart tones. So this is something that we tend not to see. We tend to see the hypotension and possibly the JVD, and then we recognize this by mechanism of injury as well. So if they have a big steering wheel print in the center of their chest, I'm thinking they're at risk for cardiac tamponade. And if I start seeing the signs of shock, if I see that, electrical alternans, I'm going to be, even more suspicious that they have cardiac tamponade, and that's their issue. So the body, compensates just like everything. It's going to breathe faster, heart's going to beat faster as they become more and more hypoxic. As that brain becomes more and more hypoxic, their level of consciousness is going to drop. They're going to be pale. They're going to be diaphoretic. They're going to turn blue. And I'm looking for that mechanism of injury that would lead me to believe that tamponade is going on. This is just, a little comparison between tamponade and tension pneumo. With tension pneumo, it's much more respiratory based, so even though you have an increased heart or an increased respiratory rate with tamponade as well, you don't necessarily have the increased work of breathing that you would see with your tension pneumo. You won't see all those accessory muscle usage. You won't see the abnormalities in the chest wall movements. Both tend to have distended neck veins. With cardiac tamponade, the trachea will stay midline, whereas you might see, as a late sign, deviation in a tension pneumo. Your breath sounds are going to be good on both sides for a tamponade, whereas they're going to be decreased or absent on the affected side in a tension. And percussion, you're also going to see some differences. But again, I don't know a whole lot of people that do percussion. Your heart sounds are much more muffled with tamponade because you have to hear them through fluid. So it's a lot like, listening underwater. It's much more muffled. You can still make things out, but it's much more difficult. All right, and this just shows you a picture of what we're looking at. So that sac around the heart fills up with blood. You get blood backing up because it can't fill this heart, so you get JVD. You start to get, changes in your ECG. Your patient's going to appear shocky because of that reduced cardiac output, and you may have muffled heart tones. All right. What are we going to do for them? Recognize them and get them to a trauma center. What they're going to need is a pericardiocentesis, which is where they put that ginormous needle in to the body. They tap into that pericardial sac, and they draw that fluid out. All right, so they'll either do this through the abdomen or directly through the rib cage when they do that. All right, so so if you can imagine that, big old needle, poke into that pericardium, drain the blood out, allow the heart to fill completely with blood and operate as normal. All right. You can also have myocardial contusions, and we think about the process, right? So we tend to see these with sudden decelerations. So they're driving along and smack into a tree, smack into a brick wall, smack into another car. They go from 70 miles an hour to 0 miles an hour very quickly. And you have the car hitting the tree, you have the body hitting the car, and then you have the internal organs hitting the outside of the, or hitting the inside of the body there. So it's a lot of force that's transferred through, and just like we talked about with pulmonary contusions, it's just like a bruise on that heart. And bruised muscle doesn't work as well, becomes swollen, it's sore, and doesn't function, doesn't get the oxygen as well as healthy tissue, so it doesn't function as well. And that, of course, is a problem, because if our heart isn't functioning well, then you're going to have the body not functioning well. Right, so common to see dysrhythmias during this, and what it means by ectopic activity is you're going to see PVCs or PACs or PJCs, something abnormal, those abnormalities, those ectopic abnormalities. Reentry pathways, they might run into an SVT state, or any other dysrhythmias can occur. when you actually have a contusion so great that it causes a structural change, you get, a bursting of a vessel. While that's very rare, it's almost immediately fatal. So this is where, that heart hits the inside of the body. It was going 100, now it's going 0. All of that impact is on that heart, and it can actually blow out an entire ventricle. Alright, so myocardial contusion, they have chest pain, usually a sharper chest pain as opposed to the dull that we normally see with MI. I'm going to look again at mechanism of injury, so I expect to see some decat BTLS over the front of that chest. And, often right around, if it bruised the heart, there's a good chance it bruised the lungs, so I might hear some crackles and rails from that pulmonary contusion that goes around it. And, like we said, there's often some ectopy in there, EKG. What are we going to do? Recognize the issue and get them to a trauma center. Alright, so we're going to do supportive care, we're going to do fluid resuscitation, give them some O2. Before we start treating those dysrhythmias, we want to contact med control just to find out what they want us to do with it, because those dysrhythmias might be the only thing that's keeping the heart functioning when it's in that damaged state. Myocardial rupture is kind of what I was talking about before, where you have some extreme structural changes, and that's usually due to perforation of either the ventricles, the atria, the septum between the two ventricles, the septum between the atria, the septum or the wall between those two. The chordae tendineae and the valves can be pulled apart. So we typically refer to as myocardial rupture, and that is relatively fatal, relatively quick. So it's a pretty big issue. Can also, so this can be from severe blunt force trauma, but it also could be from some penetrating object, either from the outside or bone fragments from a fracture that occurred inside. Alright, so oftentimes these patients will present with pulmonary edema that comes on like that. Will also show signs of cardiac tamponade, mostly because the blood is bleeding into that sac. And really it's just recognition and getting them to, should get them to that hospital. Alright. And then we'll need to have surgery to go in and repair whatever structure was damaged. Commotio cordis is causes an RNT type phenomenon, where if you get a direct blow to the chest that hits out during that relative refractory period, it can actually send them into a lethal dysrhythmia. So we see this more often in sports, where you might have a baseball player, so a ball comes right off the bat and smacks somebody right in the center of the chest. They can actually just drop and go right into cardiac arrest right there, just because it interrupts that electrical conduction. And so they go unresponsive like that, and then you might even have some seizures that go along with that as well, but typically they just drop and go into cardiac arrest. You might see some signs of whatever hit them on the chest wall, so you're looking at mechanism of injury, what happened. So often you'll get this from the history, similar to your tamponade, where you can't necessarily do something to figure out exactly what happened. You can just get the history and speculate as to what caused this. Right. About that a little bit already. Aortic disruption. So this happens often because of shearing forces. So Again, if somebody is rapidly decelerating, you have to think about it. That heart is kind of dangling in the center of the chest, and the aorta is holding onto it. So if that car hits the tree, the body hits the steering wheel, and the inside organs hit the inside of the body, well, that heart like swings like a pendulum, and that can actually rip the aorta, causing, a tear, causing them to bleed out. Now, again, this is something that can be devastating, and 1 in every 5 deaths of blunt trauma include transection of the aorta. So that's 20% of those blunt trauma cases that die have something to do with a tear in the aorta or a complete dissection of that aorta. So remember, we have our different layers of our arteries. You have your innermost layer, the tunica intima, so that's the inside. The blood is flowing inside of that little tube. On the outside, you have your tunica media, where is the muscle that controls the diameter of that vessel. And then you have your tunica adventia, which is the outer lining of that vessel. So when we get those tearing sensations, it can break through either one or more of these layers. And obviously, if it goes through all 3, they're gonna, likely bleed out. And you gotta think about it. The aorta is about the size of a garden hose. So if you get a hole in that, it bleeds out. They bleed out pretty quickly. If you get a slight tear in one of these layers, then what you'll have is an aneurysm will develop, and it will balloon out, and it will bleed into that space until it can no longer stretch any longer, and then that will burst. But it at least would buy you some time to, again, get them into the hospital. So I think all you're seeing here is the risk of it happening here in this section. An odd picture. All right. Typically, what people describe this as is a tearing sensation, usually behind the sternum or like right in the back under the scapula. They are hypovolemic very quickly, and in fact, you might even see a change where their arms might be pink, warm, and dry, or a little, pale, a little clammy, but their legs might be completely cyanotic, and diaphoretic, just depending on where that tear is. So if it's lower than where the brachial arteries branch off, then they might be perfusing up above, but no longer perfusing past that, depending on how severe that break is. All right. So again, they're going to show signs of shock, and depending on where it is, they might, if it's higher, and puts pressure on the trachea, and on the airways. No, I was thinking of a different thing. Sorry. So, because this is, typically from a deceleration injury, there may not be any signs of external trauma, but you'll know from the mechanism of injury and how they're presenting that they're, shocky in a second, and there's a good chance that you had some sort of aortic disruption. Definitely important to check the extremities, because depending on where the tear is, you might have pulses present in the right arm but not in the left arm, or in the right and left arms but not in the legs, like I mentioned. Alright. And again, they need diesel treatment because they need a sharp knife and a cold table to help them out. And some of the things that would make me suspect that they have this injury is if they have, significant mechanism of injury with multiple rib fractures, flail segments, a scapula or sternal fracture. Again, that takes an incredible amount of force. If there's pericardial tamponade, hemos and pneumos, and even clavicle fractures that are based on direct impact. Again, we're going to give supportive care, establish their airway, give them oxygen, and remember when we're treating circulation that we don't want to overload them with fluids. We want to keep them on the low side of normal, keep them at about 90 systolic so that we don't cause them to bleed out faster. If we increase the pressure in that hose, it's just going to bleed faster. And all we're going to be doing is pumping out the good blood and filling it back up with saline, which is not able to carry oxygen. So making pink blood isn't a good idea. We just want to keep them perfusing, keep their brain perfusing as much as possible. Right. We don't want to use vasopressors because we don't want to increase the pressure in that vessel. All right. Again, because when we're talking about the vena cava, they're on the low pressure side of the house. They sit, relatively in a very well protected space. They don't necessarily have, as much of the heart hanging on them as the aorta does. So injuries to this tend to result from more penetrating trauma. So actual penetrating trauma that hits the vena cava and causes them to bleed out. We'll see that much more than just movement issues. What are we going to see when this happens? A decrease in our preload, which causes a decrease in our cardiac output, so they're going to seem a little bit more shocky. We might have a hemothorax that goes along with this if it's on a spot that's very close to the heart. If that's what gets damaged, then we're going to look at cardiac tamponade. And again, it's going to be based on our history. That's how we're going to figure out this is going on, and we're going to do supportive care en route to the hospital. Alright, so our last main type of injuries are injuries to the diaphragm, and then some other structures like the trachea and the esophagus, so we'll cover those quickly. Obviously, the diaphragm is incredibly important in our breathing, so if it's damaged, we're going to have a pretty big issue. Thankfully, it's not often damaged with our trauma patients. Usually it's a result of direct penetrating issue or injury, or if blunt force causes an actual rupture in the diaphragm, in that muscle. That's where we tend to see the issues. Once that injury occurs, it's very difficult to fix, and you got to think about the diaphragm is the border between the abdominal cavity and the thoracic cavity, and there's a big pressure gradient between the two of those. So the thoracic cavity tends to be on the low, tends to have a negative pressure in it much more often, whereas the abdominal cavity tends to have a higher pressure in it. So that higher pressure will actually push into the thorax. So you'll see the abdominal organs push into the thoracic cavity. So we have different phases of these injury. The acute phase we talk about is the actual injury right when it happens. The latent phase tends to come in after that occurs. You'll actually see herniation of those abdominal organs pushing through into the thoracic cavity, and then as that diaphragm starts to contract, it can actually herniate or obstruct those organs. It can actually squeeze those organs that are somewhat protruding through into the thoracic cavity, which can cause an obstructive issue. When those abdominal organs do push into that thoracic cavity. It pushes those spongy lungs right out of the way, starts pushing pressure on the lungs and the heart, and can greatly inhibit the lungs' ability to bring in oxygen and the heart's ability to pump blood around the body. So we're going to likely see them in that acute phase when the damage has just occurred and that movement of abdominal organs has just started to push through. If you ever hear bowel sounds when you're listening for lung sounds, that's a really bad sign. Alright, so that means that there's been some breach in that wall, in that diaphragm, and abdominal organs are moving into that thoracic cavity. That's probably going to be one of our only ways to really identify it, except, based on history, but really what would clue us in, since we don't have these x-rays in the field, is the fact that we hear bowel sounds when we're listening for lung sounds. Really bad sign. Alright, so how's that going to present? Difficulty breathing. They're going to, be a little shocky. They could have some chest pain because of the pressure it's putting on the heart. And you can have diminished or absent breath sounds where those organs are pushing in, and you'll hear bowel sounds instead. Alright, when it's obstructive, when we've actually started to obstruct those abdominal organs because they're pushed into that cavity through a small space, and that small space is getting even smaller, you might see nausea and vomiting, cramping, distension, pretty much everything that you would see if your abdominal organs were being squished. Alright, so what do we need to do? Well, we're going to provide supportive care. We're going to keep the airway open. We're going to breathe for them if we need to. We're going to get IVs established to provide circulation support as well. We may elevate the head of the backboard. Again, try to let gravity work with us to pull on those abdominal organs to keep them from just rising and filling the thoracic cavity. That positive pressure ventilation might be necessary again to try to overcome the pressure that's created by those organs being in the wrong cavity. And then we might place an NG tube if it's in your protocols, just to relieve some of that gastric pressure. Relieving some of that gastric pressure can relieve pressure inside that thoracic cavity if that was expanded and putting pressure in there. Alright. Esophageal injuries. The bad thing about esophageal injuries is that they are wrapped with veins. There's veins that go all around the esophagus. We talked about that when we talk about esophageal varices. So anytime that you have a rupture or damage in that esophagus, this is an incredibly vascular area, and their risk of bleeding out is pretty severe. And also, based on where it lies, the esophagus lies just behind the trachea. So if you were able to damage the esophagus, guess what else got damaged in the process? So typically the trachea has also had some issues. Not a whole lot we can do for them. Don't give them anything orally. We don't normally do that anyway. But there's usually some hole, and it would just leak out through that hole into the body as opposed to going down to the stomach. Recognize it, get them to the hospital. When we talk about trachea or bronchial injuries, a lot of times this is caused by a penetrating injury, where whatever is penetrating just happens to nick that somewhere in that tree, causes a hole that opens up. So this can easily progress to a tension pneumo, but wherever that hole was, air wants to leak out of there because it's the path of least resistance, instead of filling up this lung. So the lungs, again, don't fill up, don't have good oxygen or carbon dioxide exchange, because there's actual damage to the internal parts of that system. You might see bloody sputum, they might cough up blood, depending on if it's closer to the upper part of the trachea, there could be hoarseness, swelling in that area that can occur, but typically it will look a lot like a pneumothorax, right? So they'll be having difficulty breathing, rapid heart rate to try to compensate for it, and then the big additions are bloody sputum and that hoarseness that occurs. All right, so we want to avoid positive pressure ventilation if we can, because all that's going to do is push that air into that thoracic cavity faster, causing them more of a problem. All right. The last big thing that we'll talk about is traumatic asphyxia, and this kind of combines a little bit of everything. And this is basically, the thorax is trapped between a rock and a hard place, so you get that compression. We see this, I think like a typical thing that you see this in is somebody's working on their car, the jack fails, and the car falls on their chest. So there's a ton of pressure. Obviously, we're not getting good ventilations, right? They're not able to take a deep breath. They might not be able to move their chest at all. All of their vessels are being compressed, their heart's being compressed, and you see all of that blood backing up into the system. So you'll see all of this swelling in the face. You'll see petechiae, which are the little capillaries in the face, or whites of their eye will burst. Tongue swells. Just imagine, if I'm squishing him at the chest, where is all that blood going to go? So it pushes up to the head. It might push out to the legs. But in the head, there's only so much room for it. So what happens is all those little blood vessels explode, basically. Those little capillaries engorge and then burst, and you see just this, basically bruising, or these little small tiny red dots known as petechiae. You get a ton of cyanosis because blood was circulating to that point. Now it's not, and they're becoming cyanotic. What can we do? Well, this is one of those things that, depending on where they're pinned, we're going to need assistance to get whatever's trapping them off of them. We're going to give them high flow O2 right away. Get some IVs established while we're trying to get whatever's on them off, and get a monitor on them right away. They're going to need, rapid transport to a trauma center. If we can get flight en route, so that they can go to a trauma center immediately once they're removed, call for them early, and go from there. All right. So that's pretty much it. If you have any questions, please, talk to us on the online meeting. Have a great day.